Welcome to this explainer. Today, we're uncovering the precise mechanisms behind two absolute pediatric emergencies: hemolytic uremic syndrome, or HUS, and acute kidney injury. So let's just dive right into this, because we're going to take a microscopic look at exactly how and why the kidneys fail under distress.
But first, consider this. Why would treating a bacterial infection actually trigger a life-threatening kidney crisis? I mean, it goes against literally every instinct we have in healthcare, right? Well, stick around because we are going to uncover an incredible antibiotic paradox that is absolutely vital for patient safety.
Here's our roadmap for today. We're going to cover the link between HUS and AKI, trace the HUS domino effect, explore that antibiotic paradox I just mentioned, categorize acute kidney injury, and finally, navigate hyperkalemia management.
All right, Section 1, the HUS and AKI link, a very dangerous connection.
You know, what's truly fascinating is just how deceptive the beginning of this crisis actually is. HUS is one of the most frequent causes of acquired acute kidney injury in infants and young children, but it doesn't start in the kidneys. It typically begins with a prodromal illness, most often gastroenteritis with bloody diarrhea, that happens about 1 to 2 weeks before the sudden kidney failure. And the most common culprit? It's a Shiga toxin-producing strain of bacteria called E. coli 0157H7. So the classic exposures you really want to look out for are things like undercooked ground beef, unpasteurized dairy or apple juice, and, believe it or not, petting zoo visits.
Moving on to Section 2, HACE, the domino effect, a chain reaction of injury. So how do we get from a simple gastrointestinal bug to total kidney failure? Let's walk through this biological chain reaction together, because it's essentially one continuous, fascinating mechanical story. Okay, domino 1. The E. coli toxin enters the bloodstream and specifically targets and damages the endothelial lining of the small glomerular arterioles in the kidney. Domino 2. In response to this injury, the endothelium gets swollen and platelets aggregate, forming microthrombi, basically tiny blood clots that partially occlude these tiny vessels. Domino 3. As red blood cells try to squeeze their way through these swollen, clot-filled vessels, they're mechanically sheared and destroyed. And finally, domino 4. Because those tiny glomerular vessels are totally blocked with clots, the glomerular filtration rate, or GFR, just plummets. The filtration system is completely blocked. And honestly, this brilliantly illustrates why you absolutely do not need to blindly memorize the symptoms of HUS. The entire classic triad of HUS emerges directly from that exact sequence we just discussed. Think about it. The mechanical shearing of the red blood cells, that gives you hemolytic anemia. The consumption of platelets to form those tiny microthrombi, that gives you thrombocytopenia. And the blocked filtration in the glomerulus, that gives you acute kidney injury. If you understand the dominoes, the whole triad just makes perfect clinical sense.
But keep in mind, the damage isn't strictly limited to just the kidneys and blood. About 20% of children with HUS actually develop central nervous system involvement. This can range from agitation and confusion all the way to seizures, stupor, or even coma. So the crucial takeaway here is that seizure precautions must be a routine, proactive part of your nursing care for a child with HUS. It can't just be an afterthought.
Let's hit Section 3, the antibiotic paradox. This is a critical safety alert.
This brings us to a major plot twist regarding how we manage the underlying E. coli infection that triggered this whole cascade in the first place. And guys, this is a massive safety hazard. When a patient has a severe bacterial infection, our typical nursing instinct is, of course, to administer antibiotics. But in the case of E. coli-associated HUS, antibiotics are strictly contraindicated. Literally, do not give them.
You might be wondering why. Well, because treating the E. coli with antibiotics actually causes the dying bacteria to rupture. And when they rupture, they release massive amounts of additional Shiga toxin into the body. So you aren't helping the situation at all. You are heavily compounding the crisis and accelerating that domino effect we just talked about. This is a highly tested concept and an absolutely critical piece of patient safety.
Okay, Section 4, categorizing AKI, the 3 plumbing classes.
Now, let's zoom out just a bit. We've talked about HUS, which is an intrinsic cause of kidney injury, but let's categorize acute kidney injury as a whole. Acute kidney injury is the sudden inability of the kidneys to excrete waste and regulate fluid. I actually really like to use a plumbing analogy to understand the 3 main classifications. First, you have prerenal causes. This is a problem with the water supply before it even reaches the house, meaning decreased blood perfusion to the kidney, usually from things like dehydration, shock, or burns. Next, intrinsic causes. This
This is damage to the plumbing inside the house, direct damage to the kidney tissue itself, like we literally just saw with HUS, or maybe from nephrotoxic drugs. And finally, postrenal causes. This is a clogged drain after the house, an obstruction like a kidney stone or a tumor that's blocking the urine from leaving.
An incredible takeaway here is that prerenal causes are both the most common and typically the most reversible. The core concept of AKI is that it's sudden and often reversible. If you restore the kidney's blood flow quickly enough, say by treating the underlying dehydration, the kidney function tends to recover completely before any permanent cell death occurs.
So when AKI hits, the hallmark clinical finding you're monitoring for is oliguria, which is defined as a urine output of less than 1 milliliter per kilogram per hour. Notice we are specifically saying oliguria, which is decreased urine, not anuria, which would be a total lack of urine. Ongoing tracking of urine output against this exact threshold is honestly one of the most vital bedside assessments you'll perform.
All right, last part. Section 5, managing hyperkalemia, shifting versus removing.
When the kidneys stop filtering urine, toxins and electrolytes build up fast. And because the kidneys can't excrete potassium during AKI, it builds up in the blood, creating a severe threat to the heart. You have to initiate immediate evaluation and intervention if the serum potassium exceeds 7 milliequivalents per liter, or if you see specific ECG abnormalities, things like prolonged QRS complexes, depressed ST segments, and those classic high-peaked T waves. If you see those, it means a cardiac arrhythmia is imminent.
So how do we fix it? Well, here's how the intervention toolkit breaks down. First up, we give calcium gluconate IV to stabilize the cardiac membrane. Next, we might give sodium bicarbonate or a combination of glucose and insulin IV. Both of these work by transiently shifting potassium from the blood into the cells. And finally, we give sodium polystyrene sulfonate, which binds the potassium in the gut and physically removes it from the body.
Now, let's see how this builds together, because this is a massive exam focus. Calcium gluconate acts only as a shield. It protects the heart muscle from the high potassium, but it does absolutely nothing to lower the actual potassium level in the blood. It basically just buys you time to implement the other therapies. And you really must understand the distinction here between shifting and removing. Insulin and bicarb, they just hide the potassium inside the cells temporarily. They lower the blood levels for a bit, sure, but the potassium is still inside the body. Sodium polystyrene sulfonate, which you might know by the brand name Kxalate, is the only medication we've mentioned that actually binds to the potassium in the digestive tract and excretes it entirely. It's the only one that actually takes the trash out of the house. Oh, and one final safety note for managing an AKI patient. You must vigilantly review their medication list. An already impaired kidney simply cannot safely clear drugs. Avoiding nephrotoxic medications is absolutely critical to prevent toxic accumulation and further intrinsic damage to those kidneys.
So to wrap up our explainer today, I'll leave you with this scenario. If a child arrives in your care seemingly recovering from a nasty GI bug with bloody diarrhea a week ago, but today they look unusually pale, they have unexplained bruising, and their parents mention they aren't urinating much, will you recognize the dominoes falling? Will you immediately look for that classic triad? Hold off on the antibiotics, and jump right into action to protect their kidneys and their heart? By understanding the exact pathophysiology we covered today, I'd say you'll be more than ready. Thanks for joining me on this explainer.